Upper airway pathophysiology is an important area of focus as disorders in this region disrupt airflow and significantly impact ventilation. These conditions often lead to partial or complete airway obstruction, presenting major challenges to maintain effective breathing. We categorize upper airway disorders into three main groups. First are obstructive disorders, caused by physical blockages such as foreign bodies or tumors. These create turbulence and increase airway resistance, forcing the patient to exert more effort to breathe, which can result in respiratory fatigue. Second are inflammatory conditions like epiglottitis or severe allergic reactions. These trigger the release of inflammatory mediators such as histamines and cytokines, leading to swelling, tissue edema, and a narrowed airway lumen. Persistent inflammation can escalate, creating a cycle of irritation and swelling that might lead to complete obstruction. Lastly, neuromuscular dysfunctions involve a loss of airway muscle tone or nerve function. Examples include vocal cord paralysis or laryngospasm, where the airway may collapse or fail to open properly. This increases the risk of aspiration and further complicates airflow and oxygenation. So now let's take a look at each of these categories in a bit more detail. Obstructive disorders of the upper airway can arise from either anatomical or functional blockages, each posing unique challenges to airflow. Anatomical blockages occur when a physical object, such as a foreign body, tumor, or a congenital anomaly, partially or completely obstructs the airway. These blockages create physical barriers to airflow and require targeted interventions to restore patency. In contrast, functional narrowing results from dynamic changes into the airway, such as in vocal cord dysfunction or laryngospasm. Now, these conditions can cause transient but significant airway compromise. Acute obstructions are life threatening and demand immediate intervention. Some common causes include choking on foreign bodies, severe allergic reactions leading to laryngeal edema, or trauma that compromises the airway. Chronic obstructions, such as those caused by slowly growing tumors or polyps, develop over time. Symptoms may be mild initially, but often can become worse, leading to respiratory compromise and additional complications if left untreated. Recognizing whether an obstruction is acute or chronic guides both the urgency and type of intervention needed to restore effective airflow. Now, you'll appreciate there is some crossover between the categories, but the principles of recognizing what type of upper airway obstruction you're dealing with will help guide your treatment later on. Inflammatory upper airway disorders involve swelling and edema that narrows the airway and restricts airflow. These conditions are often caused by stuff like epiglottitis, allergic reactions, or infections that inflame the tissues of the upper airway. This inflammation increases airway resistance, making it harder for patients to breathe. They may need to exert more effort with each breath, which can lead to respiratory fatigue. If left untreated, persistent swelling can progress to complete airway obstruction. The challenge with treating inflammation is identifying what is causing it. Not every upper airway disorder that causes inflammation will be responsive to the same type of treatment. An example, inhaled epinephrine will be effective in treating epiglottitis, but it won't be effective in treating ACE-induced angioedema. While these two pathologies can initially look very similar, recognizing and understanding the differences can vastly change the outcome of your patient. Neuromuscular disorders occur when the muscles or nerves controlling the airway lose proper function. This can result in partial or complete airway collapse, leading to obstruction. Common causes include vocal cord paralysis, where the cords fail to open, or laryngospasm, where they contract forcefully and close the airway. These dysfunctions not only block airflow, but also increase the risk of aspiration, as the person is no longer able to protect their own airway. With impaired reflexes, airflow becomes unpredictable, making ventilation ineffective and oxygen delivery to tissues insufficient. People require a significant amount of central nervous function in order to maintain their own airway. In cases where the patient is profoundly altered, they may be unable to protect their own airway from aspiration, or they may be unable to manipulate their air passageways to create the internal pressures necessary for ventilation, in which case we would need to ventilate for them. Now, although we didn't include these in our main categories, another important set of pathology to consider with the upper airway is going to be congenital and structural disorders, which can fall into any one of those three main ones. Congenital and structural disorders of the upper airway can either be present from birth or they develop over time, significantly impacting airflow and ventilation. Congenital malformations include conditions like laryngomalacia and tracheomalacia, where the larynx or trachea lacks structural integrity and collapses during inspiration. Another example is conal atresia, a blockage or narrowing of the nasal airway that can severely impair breathing in infants. Structural abnormalities, such as a deviated septum, nasal polyps, or enlarged tonsils, can also restrict the airway. These conditions can cause chronic nasal obstruction, and they can lead to complications like sleep disordered breathing, depending on the severity of the obstruction. Upper airway disorders often present with distinct signs and symptoms that reflect the degree and location of the obstruction. Stridor is a hallmark sign of upper airway obstruction. This high pitched sound, most often heard on inspiration, indicates turbulent airflow through a narrowed airway. The type of stridor can provide clues to the obstruction's location. Inspiratory stridor points to laryngeal or pharyngeal obstructions, while biphasic stridor often signals severe narrowing, such as in tracheal stenosis. Now, voice changes, such as hoarseness, breathiness, or even loss of a voice, suggest laryngeal involvement. These symptoms result from disruptions in normal function of the vocal cords due to inflammation, nerve dysfunction, or mechanical obstruction. Drooling and dysphagia, or difficulty swallowing, are particularly concerning when paired with signs of respiratory distress. These symptoms indicate significant swelling or obstruction, as seen in conditions like epiglottitis, and they require immediate attention. As the obstruction worsens, patients exhibit increased effort to breathe. Accessory muscle use, nasal flaring, and retractions of the chest are clear signs of an increased work required to overcome airway resistance. Finally, there's critical signs such as silent chest and cyanosis. Now, these are ominous indicators of complete airway obstruction. Cyanosis results from severe hypoxemia, while a silent chest reflects the complete absence of airflow. These signs demand immediate intervention to prevent respiratory arrest. A particularly lethal obstruction of the upper airway are foreign body obstructions, which can quickly progress to complete airway blockage and respiratory arrest. When a foreign object blocks the airway, it disrupts the normal flow of air to and from the lungs. Foreign bodies can become lodged at any point along the upper airway, from the nasal cavity to the trachea, with consequences that depend on the object's size, shape, and location. Obstructions in the pharynx or larynx are particularly critical because these areas are narrower and more vulnerable to complete occlusion. Now, foreign body obstructions can be classified as either partial or complete. In a partial obstruction, the object blocks the airway but still allows some air to pass through. However, the airflow is turbulent and less efficient, often requiring greater respiratory effort. Patients with partial obstructions may exhibit stridor if the obstruction is higher in the airway, or wheezing if it's down lower. A complete obstruction, on the other hand, prevents any airflow, leading to hypoxemia, loss of consciousness, and potentially cardiac arrest within minutes if it's not resolved. While the body's natural response is to cough reflexively to expel the object, the mechanism can fail if the foreign body becomes tightly lodged or if the individual cannot generate an effective cough. Swelling or airway spasm around the obstruction can further worsen the situation. If the tissue around the object swells to the point that it cannot be removed without surgical intervention, it can lead to dire consequences for the patient. Certain populations are more prone to foreign body obstruction. Young children, especially those under 5, are at the highest risk. Their airways are narrower, and their natural tendency to explore objects orally puts them in danger. Neurological impairments, such as those seen in patients with neuromuscular disorders, also increases risk by affecting swallowing or muscle coordination. Eating habits like talking, laughing, or moving around while eating can lead to accidental aspiration of food or other objects. And finally, specific types of objects are frequently involved, such as small toys, food items like nuts or grapes, and coins. The clinical presentation of foreign body obstruction depends on the location and degree of airway compromise. In acute cases, patients typically present with sudden respiratory distress accompanied by coughing, gagging, or choking. They may instinctively clutch their throat or mouth in what's known as the universal choking sign. And again, as we mentioned earlier, stridor is a common sign when the foreign body is lodged in the upper airway, such as the larynx or trachea, in contrast to when it's down lower and the patient may demonstrate wheezing. For complete obstructions, patients are unable to speak or vocalize as no air can move through the airway. This is an important, critical red flag that indicates severe airway compromise. Without intervention, cyanosis, altered mental status, and loss of consciousness can quickly follow due to hypoxemia. In chronic or delayed presentations, a persistent, non productive cough may suggest a partially obstructed airway. If the foreign body remains lodged over time, it can cause recurrent respiratory infections such as pneumonia or lead to voice changes from irritation near the vocal cords. Now, these symptoms often progress gradually and require thorough evaluation to identify the underlying cause. Dysfunction in the lower airway, which includes the trachea, bronchi, bronchioles, and alveoli, can significantly compromise respiratory function and lead to life threatening conditions. Several mechanisms can disrupt normal lower airway function, including airway obstruction, ventilation perfusion mismatch, diffusion impairment, and altered lung compliance. Now, we'll look at each of these in detail coming up next, but we'll start with obstruction of the lower airway, as it's a common cause of lower airway dysfunction. It occurs when airflow is impeded within the respiratory tract, increasing airway resistance and reducing airflow. Some key contributors include bronchospasm, which involves the constriction of smooth muscles around the bronchi and bronchioles, as seen in conditions like asthma. Mucus plugging, where excessive mucus production accumulates and blocks the airways, commonly occurring in conditions like chronic bronchitis or cystic fibrosis. Foreign bodies, which can suddenly and severely block the airways if inhaled, often leading to acute respiratory distress, and airway edema, where fluid accumulates in the interstitium or alveoli, which can be caused by inflammation, allergic reactions, infections, or inhalation injuries. Now, these obstructions increase the effort required for ventilation, causing wheezing, shortness of breath, and hypoxemia. If the obstruction progresses to complete blockage, it can result in respiratory failure. Ventilation perfusion mismatch occurs when there's an imbalance between the air reaching the alveoli and the blood reaching those alveoli via the pulmonary capillaries. A high VQ mismatch happens when ventilation exceeds perfusion, as in pulmonary embolism, where a blood clot blocks blood flow to the alveoli. Even though air reaches the alveoli, oxygen cannot enter the bloodstream due to inadequate blood flow. A low VQ mismatch occurs when perfusion exceeds ventilation. Now, this is often seen in airway obstruction, such as asthma or mucus plugging, and in pneumonia, where fluid and inflammation reduces airflow to the alveoli. Both types of mismatch lead to impaired gas exchange, which results in hypoxemia. A pulmonary shunt occurs when blood flows through the lungs but doesn't participate in gas exchange because the alveoli are not ventilated. Imagine alveoli being collapsed or filled with fluid, like in cases of atelectasis or pneumonia or pulmonary edema. This creates a mismatch between ventilation and perfusion. What makes shunts distinct is that they don't respond well to supplemental oxygen. Even if we flood the lungs with high levels of oxygen, it doesn't really matter because the oxygen can't reach the blood. To address this, we often need to use positive pressure ventilation like CPAP or mechanical ventilation to help reopen or recruit those alveoli and restore ventilation to the perfused areas. Now, your lungs react to pulmonary shunting with hypoxic pulmonary vasoconstriction, which helps direct blood flow to other areas where gas exchange can occur. Intrapulmonary arteries constrict in response to alveolar hypoxia, diverting blood to better oxygenated lung segments, which optimizes ventilation perfusion matching and systemic oxygen delivery. Of note, hypoxia can cause peripheral vasoconstriction as well. Essentially, any tissue that is hypoxic will respond by initially vasoconstricting to try and redirect blood flow through better oxygenated segments. Interestingly, the lungs react to high VQ mismatch in a similar fashion. Although air reaches the alveoli, blood flow is restricted, preventing oxygen from being absorbed. This creates areas of the lung where oxygen cannot reach the bloodstream, reducing overall oxygen levels and leading to hypoxemia. To compensate for this mismatch, the body attempts to optimize gas exchange by constricting the bronchioles that feed the poorly perfused alveoli. Now, this reduces wasted ventilation by redirecting airflow to areas of the lung that still have adequate blood flow. It's the respiratory system's way of prioritizing efficient oxygen exchange, even when things aren't functioning optimally. Diffusion impairment refers to a reduction in the efficiency of gas exchange across the alveolar capillary membrane. If gas can't effectively transfuse through the alveolar membrane, it can't make it to the pulmonary capillary network. One key cause is a thickened alveolar capillary membrane, as seen in pulmonary fibrosis. In this condition, chronic inflammation leads to scarring and fibrosis of the alveolar walls. The increased membrane thickness adds to the distance over which gas must diffuse, making gas exchange less efficient. Another major factor is a reduced surface area for gas exchange, as occurs in emphysema. The destruction of alveolar walls and the merging of alveoli into larger spaces significantly reduces the available area for oxygen and carbon dioxide to transfer. This loss severely impairs the lungs' capacity to oxygenate the blood. The consequence of diffusion impairments are evident in symptoms such as dyspnea, particularly during physical activity when oxygen demand increases, and patients may also experience fatigue, tachypnea, and cyanosis due to inadequate oxygenation. Now, to really understand diffusion impairment, we need to appreciate Fick's principle, which is the physics that explains the factors influencing gas diffusion across a membrane. Now, Fick's law of diffusion states that the rate of gas transfer, denoted as V, depends on four key variables. The first is A, or the surface area available for diffusion. A larger surface area allows more gas molecules to cross the membrane simultaneously, increasing the diffusion rate. D, the diffusion coefficient, is determined by the gas's solubility and molecular weight. Gases with higher diffusion coefficients, like carbon dioxide, diffuse more rapidly. Delta P, or the partial pressure gradient, is what drives diffusion. A greater difference between alveolar and blood gas pressure accelerates the process. And T is the thickness of the membrane. Thicker membranes increase the distance gases must travel, thereby slowing diffusion. Lung compliance refers to the ease with which the lungs expand during inhalation. It reflects the change in lung volume for a given change in pressure. When compliance is altered, either decreased or increased, it significantly impacts respiratory function and gas exchange efficiency. Decreased lung compliance occurs when the lungs are stiff and resist expansion, requiring more effort to breathe. A good example of this is something like acute respiratory distress syndrome, which is a severe inflammatory condition causing alveolar collapse due to fluid accumulation and surfactant dysfunction. This results in rapid onset dyspnea and refractory hypoxemia. In contrast, increased lung compliance occurs when the lungs are overly elastic, inflating easily but failing to recoil properly during exhalation. This is characteristic of emphysema, where alveolar destruction leads to air trapping and impaired exhalation. Trauma can have significant pathophysiological effects on the pulmonary system, often resulting in life-threatening conditions that require immediate attention. Pulmonary trauma typically falls into one of four categories: blunt trauma, penetrating trauma, blast injuries, and inhalation injuries. Blunt chest trauma, such as from motor vehicle collisions or falls, can cause pulmonary contusions, where bruising of lung and tissue leads to alveolar hemorrhage and impaired gas exchange, or it could cause rib fractures, which are also common and could potentially compromise ventilation due to pain and instability. Penetrating trauma from injuries like gunshots or stab wounds directly damages lung tissue or airways, often leading to pneumothorax or hemothorax, where air or blood accumulates in the pleural space, impairing lung expansion. Blast injuries caused by explosions result from sudden overpressure waves that damage alveoli and small airways, leading to barotrauma and pulmonary hemorrhage. Inhalation injuries, such as those caused by heat, smoke, or toxic chemicals, damage the airway lining and alveoli, leading to edema, inflammation, and impaired oxygen exchange. Each of these injuries has unique effects on the pulmonary system, and we'll take a look at them in detail coming up next. Blunt chest trauma refers to injury caused by forceful impacts that stress the thoracic structures without penetrating the chest wall. Some common causes include motor vehicle collisions, falls from significant heights, and physical assaults. Now, these injuries can have serious consequences because the chest cavity houses vital organs such as the lungs and heart, and trauma can compromise their function. Blunt chest trauma often leads to conditions such as pulmonary contusions, rib fractures, pneumothorax, or hemothorax, each with the potential to be life-threatening if not properly addressed. A pulmonary contusion is one of the most significant injuries from blunt chest trauma. It involves bruising of the lung tissue, causing alveolar bleeding and fluid accumulation. This disrupts gas exchange and leads to symptoms like shortness of breath, chest pain, bloody sputum, and hypoxia. Diagnosis relies on imaging, which shows areas of lung consolidation. Rib fractures are the most common chest injuries. While a single rib fracture causes pain and restricts breathing, multiple fractures can result in a flail chest, where a free floating segment of the chest wall moves paradoxically. This abnormal movement impairs lung expansion and worsens hypoxia. Blunt chest trauma can also lead to pneumothorax, where air enters the pleural space and causes the lung to collapse. Symptoms include sudden chest pain, shortness of breath. If untreated, it can progress to tension pneumothorax, a life threatening condition that impairs both respiratory and cardiac functions. A hemothorax occurs when blood accumulates in the pleural space, compressing the lung and reducing ventilation. It often results from injury to lung tissue or blood vessels. Patients may present with respiratory distress, absent breath sounds on the affected side, symptoms of shock such as hypotension and tachycardia. Penetrating chest trauma occurs when an object pierces the chest wall, creating an open wound that can damage vital thoracic structures. Some common causes include stab wounds, gunshots, and impalements from accidents or explosions. Now, the severity of these injuries depends on factors such as the velocity of the penetrating object, as well as the angle and depth of penetration. High velocity injuries, such as gunshot wounds, often cause more extensive damage due to fragmentation in multiple wound tracts. Now, these injuries can lead to life threatening complications, including pneumothorax, hemothorax, cardiac tamponade, and damage to major vessels or potentially the esophagus or trachea. Penetrating chest trauma often leads to several serious complications. A pneumothorax occurs when air enters the pleural space, causing the lung to collapse, whereas an open pneumothorax, or a sucking chest wound, happens when air is drawn through the wound with each breath. Symptoms can include shortness of breath, chest pain, hypotension. A hemothorax involves blood pooling in the pleural space, compressing the lung and reducing ventilation. In severe cases, called massive hemothorax, can lead to hypovolemic shock. Cardiac tamponade is a life-threatening condition where blood accumulates in the pericardial sac surrounding the heart. Classic signs include Beck's triad, which is hypotension, muffled heart sounds, and jugular venous distension. Some additional injuries include rupture of the great vessels, airway obstruction, and esophageal rupture, which can cause life-threatening infections like mediastinitis. Blast injuries to the pulmonary system occur when explosive events generate rapid pressure changes and shock waves. These injuries are common in military, industrial, and terrorist contexts where explosions cause significant damage to the chest and lungs. Blast injuries are categorized into four types. Primary injuries, caused by the blast wave, directly damage the lung, often leading to blast lung, which includes alveolar rupture, pulmonary contusions, and ventilation perfusion mismatch. Secondary injuries result from flying debris that penetrate the chest, causing conditions like pneumothorax or hemothorax. Tertiary injuries occur when individuals are propelled by the explosion, resulting in blunt trauma, such as rib fractures or pulmonary contusions. And quaternary injuries include burns, inhalation of toxic gases, and exposure to dust or chemicals, all of which can impair respiratory function. Now, blast lung is the hallmark of primary blast injuries. The intense overpressure from the blast wave causes alveolar rupture, leading to pulmonary contusions, hemorrhage, and edema. This impairs gas exchange and creates a ventilation perfusion mismatch. Patients may present with symptoms such as shortness of breath, hemoptysis, chest pain, and hypoxia. Imaging often reveals bilateral infiltrates indicative of lung contusions and fluid accumulation. Secondary blast effects occur when debris propelled by the explosion penetrate the chest wall. Now, these injuries can lead to pneumothorax, hemothorax, or hemopneumothorax, with an increased risk of infection due to contaminants introduced into the wound. Inhalation injuries occur when harmful substances like smoke, toxic gases, or superheated air are inhaled, causing damage to the upper airways, lower airways, and alveolar capillary membrane. These injuries are often seen in residential or industrial fires, chemical spills, and other confined space incidents. Now, the pathophysiology of inhalation injuries can be divided into three categories. Thermal injury primarily affects the upper airways, where heat causes burns, inflammation, and edema, leading to airway narrowing or obstruction. This may manifest as stridor, hoarseness, or respiratory distress. Chemical injury impacts the lower airways and alveoli, where toxins and particulates cause bronchospasm, pulmonary edema, and atelectasis. Toxins like sulfur dioxide and nitrogen oxides can also impair surfactant, further reducing lung function. Systemic effects result from toxins such as carbon monoxide, which bind to hemoglobin and reduces oxygen delivery, or cyanide, which blocks cellular oxygen utilization, leading to metabolic acidosis and cardiovascular instability. The clinical presentation of inhalation injuries varies depending on the severity and affected regions. Upper airway symptoms include hoarseness, stridor, burns around the nose or mouth, singed nasal hairs, and soot visible in the mouth or sputum. Now, these findings are indicative of airway involvement and the risk of edema and obstruction. Lower airway symptoms may include a persistent cough, producing blackened sputum, wheezing, bronchospasm, and shortness of breath, often accompanied by tachypnea and crackles due to pulmonary edema. Systemic symptoms result from toxins like carbon monoxide and cyanide. Patients may exhibit headache, confusion, altered mental status, and in severe cases, arrhythmias or cardiovascular collapse. Additional findings may include burns on the face, neck, or chest, and traumatic injuries from falls or explosions associated with the event.